Okay, hi everyone. This is Denise Wilson, President of the Association for Healthcare Denial and Appeal Management, and this is our January webinar. Happy 2023. Today we're going to talk about anatomy of successful medical necessity appeals, and that's because a lot of you asked for this particular topic. So we do try to honor your requests as much as possible when you have ideas for webinars that you want to see us present. So please keep your ideas coming. This is going to be a 1-hour webinar, and hopefully we'll have time for some questions at the end, 10 to 15 minutes at the end for questions. So if you do have questions, please enter them in the questions box. You should have this little control panel that popped up when you joined GoToWebinar. You also have handouts for today. If you go to the handouts area of the control panel, you should be able to download the slides for today. And I also have 2 appeal letter samples that we're going to go through today, and that is in the handouts area as well. Try your best to download those from GoToWebinar if you possibly can. If you're being blocked from downloading the handouts, because I know you're behind, a lot of you are behind firewalls, you can go to our AHDAM website at www.ahdam.org, kind of scroll down the home page, just go to the home page, scroll down until you see the notice for today's webinar, and then you'll see some gray boxes with download arrows on them, and you can download the PowerPoint from there as well as the 2 Word documents for the appeal samples that we're going to do today. So try those 2 download efforts first and see if you can get the handouts that way. If you absolutely cannot, then you can put your email address and ask for the handouts in the questions area. And my first assistant, Alice, will email those to you during the presentation. She'll do her best to email those to you. But we have a huge audience today. So if you can download them yourself, that would be great. Okay, as far as CEUs, they're offered to AHDAM members only. So you have to be a member of the association. You have until midnight tonight to sign up. If you're not a member and you do want CEUs, we will allow you a grace period if you sign up today. You have to attend the live webinar for at least 50 minutes, so make sure you stay on to the end. There is a survey that pops up with like 3 questions on it and some other information about like which CEUs do you want and what do you want to hear in upcoming webinars. So make sure you fill that out. Even if you don't want CEUs, if you want to fill out the survey, that's great because it gives us some feedback on what you want to hear going forward. So for the CEUs, though, you do have to do the survey. It pops up automatically for you as soon as I end the webinar or as soon as you leave the webinar. We will email the CEU certificates. We try to get them out within a week. So those will be emailed to you at whatever email address you registered with. They're not available for watching a recording of this webinar. We do record our webinars and post them for free on our website. And just a disclosure that there's no individuals in a position to control content for this activity that have any relevant financial relationships to declare. Okay, from the survey, if you want CEUs, these are the 5 that we offer. We did set up the surveys just a little bit differently this time. It used to be a question that said pick the ones or one that you wanted. Right now we've got it set up where there's 5 questions and you go through and say yes or no to the CEUs that you'd like. It's just going to make it a little more efficient for us on the back end to get those CEUs out to you a little bit quicker if we do it that way. So we structured the questions just a little bit differently. Our next upcoming complimentary webinar for the association is on Wednesday, March 1st at 2 p.m. and we're going to talk about different payers equal different appeal strategies. So we get asked that question a lot. How do I get my appeal to independent review? You know, what are my options when this happens? What are my options when that happens? And a lot of times the first question is, who's the payer and are you contracted? Okay, so we'll talk about that March 1st. You can sign up for that, by the way, now. The live sign up is available on our website. just go to the home page. Again, scroll down on the home page. It's getting kind of long there, and you will see towards the bottom there's a link to register for the upcoming webinar. By the way, we are going to a new website next week, and so really excited about that, and that should make it easier for all of you to be able to manage your membership, easier to sign up, and easier to access information on what we have offered for you. We also have a webinar with PayerWatch coming up next Tuesday, January 31st, and it's at 1 p.m. You can register on our homepage for that one as well. We do not offer CEUs for that one. We're going to talk about, if you haven't heard about it yet, I hope you have, that CMS has posted a proposed rule on Medicare Advantage plans. And we talked about it. We did a webinar last week with Dr. Brian Moore on talking about this proposed rule. And then on Tuesday, January 31st, we're going to present again with a little bit different take on it with Dr. Eddie Hugh. And that's free to attend. Go ahead and sign up, but no CEUs for that one. It's called Part 2 because we did a session back in the fall, I think in August, when CMS sent out a request for information on Medicare Advantage plans. Now they've published a proposed rule, and we all need to comment by February 15th. So this webinar plus the one that we did that is recorded that's on the PayerWatch website, you can watch that recording on the PayerWatch website, will give you some good background and insight into what's going on with that proposed rule from CMS on Medicare Advantage plans. A little bit about our association. We are the nation's only association dedicated strictly to healthcare denial appeal management, and we're here to support all of you who are working in this arena or this field. And the goal really is to, a couple of goals is to level the playing field between payers and providers so that we're all speaking the same language and we can have the same information, the same armament, I guess, so to speak, to be successful in appealing denials and preventing denials on the front end as well. So we're here to make your jobs easier, to bring some recognition to the field that we all work in. AHDAM was created through the generous support of PayerWatch, which is the nation's leading provider of payer denial, audit, and appeal solutions. We have at PayerWatch both software platform to help you manage your denials and appeals, and we also have services to provide appeal services for those of you who may be lacking the resources to do so. And then I've got to read through the disclaimer, and then we'll actually get into the content. So the Association for Healthcare Denial Appeal Management publishes and distributes materials on its website that are created by our members or invited industry subject matter experts for the benefit of our members. We do not certify the accuracy or authority of those materials. The materials are distributed and presented as research information to be used by our members in conjunction with other research that you deem necessary in the exercise of your independent professional judgment. We claim no liability in relation to reliance on the content of these materials. The views expressed are the views of the material's authors, do not necessarily represent the views of AHDAM. Any references are provided for informational purposes only, do not constitute endorsement of any sources. There's no conflicts of interest to declare for any individual in a position to control the content of this presentation. Okay, so me, I'm a Senior Vice President at PayerWatch and also President of the association. I've been in healthcare for well over 30 years now. Nursing is my background, but I've been doing medical necessity and level of care appeals for about 17 or 18 years now. Mostly do a lot of education and speaking these days and presenting these webinars for the association. And I invited my good friend, Dr. Kendall Smith, to join us as well today to add some color commentary to the presentation. He is our Chief Physician Advisor at PayerWatch. He's a leading appeal educator and provides appeal services for hospitals and health systems. He served as a physician leader in hospital revenue cycle management teams and served as a physician advisor for clinical research resource management. He's an AHDAM, ICD, CM, TCS approved trainer and ambassador, and just an all-around good guy. So, all right, so let's get started on our content for today. So I'm going to talk about medical necessity and what the structure of a good medical necessity appeal argument is. So I've given you a couple of letters in Word format, which is, nice that you don't have to try to copy and paste out of an Adobe, but I gave them to you so you could, start with them if you'd like to. If you don't have templates built already at your organization, that'll give you a good head start to building some templates or some framework for writing appeals. So we're going to walk through those templates as I'm going to pull them up and show them to you, but let's talk about a little bit of background before we get there. So medical necessity, when we say that, it really encompasses not only level of care, but also procedure services and surgeries. So I almost feel like in this industry, we need to carve out medical necessity and level of care as two different issues, but they're still kind of tied up under one, So if you say medical necessity, sometimes I ask, are you talking about level of care, or are you talking about a procedure or service? So I just want to make sure that we're all on the same page and speaking the same language. So level of care, we're talking about, was it medically necessary for that patient to be an inpatient in the hospital, or could they have been treated as an outpatient? Level of care can also involve, should that patient be in the ICU? Should they have been in an intermediate care bed? Should they have been in a step-down unit? When we talk about those types of level of care, we're typically talking about commercial payers in contracted language, where they may say, we pay this much for an ICU bed per day, we pay this much for intermediate bed, we pay this much for a ward bed. So that's getting a little bit more into the nitty-gritty, and I'm not going to talk about that today. I'm going to stick with inpatient level of care, and then we're going to do an outpatient case for an outpatient surgery, a total knee. So this is just kind of an outline of what a good appeal letter might look like. Okay, you've got your introduction, you've got your demographics, which is all about the patient, their insurance claim number or their insurance number, addresses, and all of that stuff. What the payer did wrong in issuing the denial is a good way to start your letter. I'm not going to talk about that today. I'm going to put a webinar together for this spring to talk a little bit more about the pushback to the payers and pointing out what they've been doing wrong in issuing their denial. So there's a little bit of that in your documents, the Word documents that I've provided for you today, but I'm not going to talk about it today. The things I'm going to talk about are in purple: the clinical presentation of the patient, the argument for the level of care. So we're talking about a level of care appeal right now, and pulling all of that together, and then standards of care we'll talk about as well. Then you can have regulatory arguments, especially if you are arguing for traditional Medicare. I usually think of that as being regulatory, but you could have some legal arguments in there as well if you're arguing back to managed Medicare or to commercial payer. Again, I'm not going to talk about that today. I want to do a webinar later this spring to cover those topics, and then your little conclusion. Okay, so the core of the medical necessity argument really comes, it seems simple when you state it, that it really is determining whether the services provided met the standard of care accepted by the local medical community. So that seems very simple, but it's not always easy or simple in practice to make that argument. And it's more difficult, I feel, for level of care than it is for outpatient services. And I'll talk about why I think that as we go forward. So what does standard of care mean? I'm going to talk about that a little bit. So standard of care, we a lot of times, or I a lot of times refer to it as evidence-based guidelines or EBGs. It really means what has the medical community accepted as being the standard to treat a particular condition after study, studies have been done, safety, efficacy, efficiency, and all of that. So what does local mean? That's a little bit more difficult to put your finger on. What does local medical community mean? So I'm going to talk about that a little bit, what I think local medical community means. Let's go back to what does the standard of care mean, and I'm just going to go to the CMS definition because they have a nice definition of it. But you could go to any payer website, and you can see what they have published as what they consider to be standard of care. Okay, this came from a HCFA 95-1 ruling, which came out in 1995, but it's still applicable today. And I have the URL there where you can go and download that. And they define their standard of care as, or acceptable standards of practice that exist within the local community as published medical literature, a consensus of expert medical opinion, consultations with their medical staff, meaning the Medicare contractors' medical staff, medical associations, including local medical societies and other health experts. So there's your local medical societies. They've thrown that in there. So what they mean by published medical literature is generally things that have been published in peer-reviewed journal articles like New England Journal of Medicine and JAMA. So it doesn't have to be those two. Obviously, there's a lot more out there than just those two. That's just the two examples that they gave. So what does local mean? So Medicare does include that in their language of standards of care, including local medical societies. So I think of it as, does the standard of care vary between rural hospitals and urban medical centers? So if you're in a rural hospital and you had all the resources available to you that they have at an urban medical center, would you provide the same care using the same tools, the same resources, the same, diagnostics, the same treatments that are being used in an urban medical center? Of course you would if you had all those resources, but a lot of times you don't. So is your standard of care a little bit different if you're in a more rural situation? Could be. And I think sometimes about whether the rural communities have access to adequate outpatient health services. But when you think about things like behavioral health, is there good outpatient behavioral health services that are available in your community? What about maternal health? Because I know a lot of rural hospitals are closing down their maternity wards. So if you're in a rural setting, is your standard of care different because patients don't have access to maternal care or behavioral health care that they would have in an urban setting? Okay, so let's talk about, this is kind of just an overview of what I'm going to go into in detail with the actual letter. So I tend to break it up into 4 paragraphs, which your letter could be longer than 4 or shorter than 4 paragraphs, but I guess I should say, 4 sections. And usually we're going to start off with what was the patient's presenting signs and symptoms. And typically they're coming into the EMS, although they might, or through the ED, although they might not. They could be a direct admit or, come from the doctor's office. But when we're kind of introducing the patient, what is the duration of the presenting signs and symptoms? What did they look like when EMS saw them? If you have access to the EMS record, because they can look a lot different in their home than what they look like once they get to the ED. Did they have any outpatient or home treatment before they came to the ED? So those are some of the things to think about in your opening paragraph. The next paragraph, I like to talk about what happened in the ED. What were the assessments? What were the interventions? And what were the outcomes of those interventions? Did the patient get better or not get better? Because that plays into your decision to admit. So we like to focus on the abnormal vital signs tests and study results, because the payers do the opposite. They say, well, look, this was normal, this was normal, this was normal. So to get rid of that noise of mixing in the normals with the abnormals, we tend to focus just on what's abnormal. And then, as I said, your decision to admit a lot of time is going to be in that, during that ED time, the patient was in the ED. So I like to kind of finish up my second paragraph with that decision to admit. What were the working diagnoses at the time? Which signs and symptoms did not adequately improve during treatment in the ED adequately enough to send them home?
Denise, one of the things I might point out on that slide, it's really important to take into consideration variations in patients that may be due to either age or medications. As people age, their ability to mount a fever response or tachycardia in response to an infection will diminish. Calcium channel blockers, beta blockers, different types of drugs can severely blunt heart rate or mask hypotension that might otherwise be present or significant. So quite often we'll recommend to our writers that they couch the abnormal vital signs if they're not there in terms of the fact that they may have been there, but for the fact the patient was on medications or got Tylenol at home, for example, that would otherwise make those vital signs appear normal and be spurious.
Yeah, very good point. Okay, and then now our patient has been admitted. Let's talk about their plan of care, because that is a huge supporter of medical necessity for inpatient admission. Does the plan of care talk about why they need to be in the hospital? So again, you can repeat the diagnoses. You don't necessarily have to if the history and physical kind of, reiterates the diagnoses from the ED. And then the plan of care, things like IV drugs and drips, is what additional testing do they plan to do, especially if it's, not just lab tests. I shouldn't say not just, but additional testing that would be like more invasive testing or more involved testing, planned invasive procedures. They're going to go in and do a thoracentesis, things like that. And your consults, the more physicians that need to consult on the case, the more complex that patient is. So those are kind of some of the things I like to talk about in my third paragraph. And then pulling it all together in the fourth paragraph, reiterating the patient signs, symptoms assessment, risks. I didn't talk about that too much, but risks of something, an adverse event occurring, what treatments did the patient receive, including hospital admission, that were supported by standards of care. And then we're going to talk about standards of care a little bit as well. You can also in your kind of summary or last paragraph talk about what risks were avoided because treatments were done. That one, I think, sometimes I'll talk about that a little bit. Sometimes I don't so much, because so many payers, especially commercial payers, I feel like they don't care about the risk. If the risk didn't turn into an actual event, they don't feel like then that's supportive of inpatient admission. But certainly you can include that in your paragraph if you were used to writing about the risks that were avoided. So the stand, let's talk about this is a procedure service. Okay, let me stop there and let's go to our letter and look at that. Okay, so we're going to do our inpatient one first. I want to make sure that shows up on your screen. Looks like it's there. Okay, so of course this is all, I always like to use real examples that we've redacted all of the information on this, changed it up so it's not recognizable. And here's our intro, here's our demographics, here's a little bit about why it was denied. Like I said, you can see that on your handouts. I'm not going to talk about that today. We're going to go straight to our 3 or 4 paragraphs and talk about those. Now, on the handouts that you all have, you don't have this red text in here. This was just so you could kind of see what I said on the slide versus what's in the letter itself. So the letter itself, of course, is going to be would be without the red in there. So our presenting signs and symptoms, this was a 73-year-old who presented to the hospital emergency department by ambulance suffering from productive cough for 2 days. So that's our duration, and a sudden onset of dyspnea. There wasn't any mention in the record about any outpatient or home treatment prior to him presenting. We do, if you've been to our webinars before, I do like to bold some of the words in our letter so that if you were doing nothing but skimming it quickly with your eyes, the pieces that are the most important are going to pop out, hopefully, to the reader and give you a good sense of what's going on with this particular patient. So our second paragraph is going to be our ED assessments, interventions, and outcomes. I think this is a very important paragraph to give the reader the sense of what this patient looked like when they presented to the hospital. So as I said, we're going to focus on abnormal vital signs, test and study results, interventions outside of the routine. So, you know, they're going to get IV fluids, of course, almost everybody does. You know, they're going to be put on a monitor, telemetry monitor, those kinds of things. I'd like to just talk about things like you know, if they're put on IV drips. This guy was put on dual nibs. He had an echocardiogram, which I think maybe is in my next paragraph. And then the decision to admit the working diagnoses in which signs and symptoms did not adequately improve. So he came in tachycardic, heart rate of 125. He was an AFib, which was not new for him. They had rapid ventricular response. He was tachypnic. He had an elevated white blood cell count, elevated BUN, elevated BNP, elevated lactic acid. Now, I like to put in there what that indicates. Okay, possible infection, kidney insufficiency, congestive heart failure. His ABG, yes, he had an EBG. I know we don't do those very often anymore, but he had an arterial blood gas, and that showed acute hypoxemic respiratory failure. So he had a very high pH and a low PCO2, and his PO2 was 73 on room air. So that's reflective of his, you know, tachypnea, trying to, you know, bring his oxygen saturation up. He's blown off his PCO2 and increased his pH. He had wheezes, rales, and stridor. So they started him IV cardizem bolus, the solumedrol, ceftriaxone, Zithro, and Geonib. And his respiratory rate, heart rate, breath sounds did not improve after treatment in ED, so the decision was made to admit the patient. So then our third paragraph, we're going to talk about him being admitted as an inpatient diagnosed with acute hypoxemic respiratory failure with underlying COPD exacerbation, his congestive heart failure with an acute exacerbation going on there, paroxysmal atrial fibrillation, leukocytosis. The plan, same as kind of continue what he was getting, what was started in the ER, and an echocardiogram. He actually required IV cardizem for 3 days total. Now, I don't always talk about what happens after they're admitted, because really the gist of your argument should be why that decision was made to admit them as an inpatient. Okay, so what happens afterwards doesn't always count, but if something happened after they were admitted that kind of helped support how sick they were at the time the decision was made to admit, I will include that. So saying that he required IV cardizem for 3 days total helps support how sick this guy was when he came in. So I hope that makes sense. Kind of why I have that particular sentence in there. Then he had an echocardiogram, which revealed an ejection fraction of 20 to 25%. Of course, we didn't know that at the time of admission either. We just knew that he was, you know, acute exacerbation of his CHF. But I think that helps, again, kind of support how sick this guy was. And then our last paragraph pulling it all together. So just making that summary of what he came into the hospital with, how unstable he was when he arrived, failure to provide aggressive treatment increased the risk for respiratory arrest. So there's talking about the risks that were present, and then how those risks were avoided because of the treatment he received in the hospital. And his providers understood care would extend beyond a period of observation because he needed time to return to baseline status, not only his respiratory status, but his CHF status, his AFib status, all of those things. This gentleman is also homeless. That's in our demographics up towards the top of the page, or the first page of the letter. So his homelessness does play into also concern for discharge. You know, are you going to, if a gentleman comes in this sick, how long are you going to keep them knowing that you're discharging him back to the street versus discharging him to his home? So, you know, that can play into your length of stay as well. Okay, so it's 4 short paragraphs. And then we're going to talk about the standards of care. So this is where we get into that definition of medical necessity that says, as long as you provided care according to the standards of care in the medical community, then you should get paid for that. So this is where we're taking his presentation and marrying it up with the standard of care. So if you've seen our templates in the past or been in our webinars in the past, a lot of times we do the standard of care or evidence-based guidelines. We have them listed in a table format. I'm kind of trying out what it's going to look like if I don't use a table, because tables, if you're not a word guru, tables are sometimes hard to deal with when you're working in a Word document. So I have this outside of a table trying to see if I'm going to like how this looks. So our first standard of care that we have documented here is the Global Initiative for Chronic Obstructive Lung Disease, or the GOLD. I call it the GOLD standard. It's the GOLD, what do they call it? GOLD report, I think is what they actually call it. It's one of my first go-tos when I'm looking for whether or not a patient requires inpatient admission. Now, a lot of evidence-based guidelines or standards of care, they're not going to come right out and say this patient needs an inpatient admission, okay? Because inpatient versus outpatient in the hospital, we can talk about how it's more of a payment strategy than it is, you know, a difference in care or whatever. But anytime a standard of care talks about hospitalization, I'm going to argue that that means they're saying inpatient. Okay, so that's what hospitalization to me means when they talk about, when I read an evidence-based guideline or standard of care. And this one gets quoted a lot when you read other journal articles on admitting patients for COPD exacerbations. They will reference this guideline quite a bit, or they will have references that are very similar to what we see here. Okay, so this one says, the GOLD report says that COPD exacerbations are defined as the acute worsening respiratory symptoms that result in additional therapy. Potential indications for hospitalization assessment. And I like how I think that's a change, but I'm not actually sure whether the word assessment has changed over the years, because they publish this every year. At the beginning of the year, they update it every year. So there's a 2023 one out there now. So this is one from 2021. So now they're not really saying hospital admission. Now they're saying hospitalization assessment. So it's interesting to see how even standards are starting to kind of step back from putting patients in the hospital so much and treating them more as outpatients. And they also have an asterisk there, which I think is new. I don't know if it was new in 2021, but I don't remember seeing that the last time I looked this up. It says local resources need to be considered. So I think that goes back to, what is your local standard of care? You know, do you have the resources to care for a patient in the way that they need, you know, when they come in with a COPD exacerbation? So they give us 6 guidelines here to think about, or indications to think about. So I have bolded the ones that apply to this patient. Sudden worsening of resting dyspnea, serious comorbidities, heart failure. Now, newly occurring arrhythmias, his was not new. He has had AFib in the past, but it was interesting because newly occurring is new. If you go back a couple of years in the Gold Report, it used to just say arrhythmia. Now it says newly occurring arrhythmia. Insufficient home support. Well, that definitely fits our guy who is homeless. Okay. So again, just go through, I could say acute respiratory failure because it was acute hypoxemic respiratory failure. I could have had that one bolded too, I think, probably. So the idea is not only to be effective in your appeal writing, but to be efficient. So if you have this snippet already built into a template or available, at your fingertips that you can pop it in here, just bold what applies to this patient, it makes a quicker appeal, because we're spending money writing appeals to try to get that money back. You can't be spending all day writing an appeal. This way, this makes it a little bit quicker to just say, look, these are the things that my patient presented with. We should consider inpatient admission being appropriate. Okay, the other one I have is managing comorbidities in COPD. And this one just talks about congestive heart failure in COPD. That's the leading cause of hospitalization and death for patients with COPD, worsens their prognosis. And presence and severity of COPD are associated with increased risk for atrial fib, atrial flutter, and non-sustained VTAC. We know he already has AFib. Hospitalization mortality in severe COPD patients with arrhythmia has been reported to be as high as 31%. So that applies to this gentleman.
Denise, the two articles you have kind of emphasize something critical, which is you don't need to drown your appeal in literature references. If you have one or two strong references that are your go-tos, that have been peer reviewed and are reasonably up to date, you can defend your level of care or need for care without going through 10 or 12 different journal articles. So having a strong library at your fingertips of one or two good vetted articles for each of your major diagnoses that are being challenged is probably the best way. You're going to tend to lose the reader if you try to drown them or fire hydrant them to death.
Okay, good point. Okay, let's switch over to our outpatient. Okay, so outpatient, a little bit simpler in my opinion sometimes, as long as you've got good documentation and and it's actually appropriate to appeal. I know some outpatient, it can be very complex because you've got to pull documentation, medical documentation from 5 different places and things like that. So they do have their challenges as well, but at least the definition of what the payer is looking for to support that outpatient procedure or service being done is a little bit more clear, I think. So when we talk about standards of care, we're going to talk about procedures, services, surgeries, even inpatient surgeries. It's often described if it's traditional or managed Medicare, there's national coverage determinations that are issued by CMS. Okay, so those are called NCDs. Those apply to traditional and managed Medicare. There's local coverage determinations, which are issued by the Medicare administrative contractors that work for CMS. Those apply to traditional and managed Medicare payers. And then I just use a general term of clinical policy bulletin for commercial payers in managed Medicare in the absence of an NCD or LCD. So managed Medicare has, if there's an NCD or an LCD that's been published by CMS, managed Medicare has to abide by those. If not, managed Medicare can create their own clinical policy bulletins, and then commercial payers have their clinical policy bulletins that they use as well, which are similar to NCDs and LCDs. Outside of those, then you would go to, if you're trying to argue the medical necessity for a procedure or service, you would look at what's been published in peer-reviewed medical journals or other specialty journals. Okay, the anatomy of an outpatient appeal, not that much different. You have your intro, your demographics, what the payer did wrong, your clinical presentation, your argument for that procedure, service, or justification for that treatment occurring. And then you're going to include your standard of care. Again, it could be an NCD, an LCD, clinical policy bulletin. In this particular case, this was a traditional Medicare. It was a RAC, Recovery Audit Contractor audit for a total knee, and this was just audited last year, actually. It was audited by Novitas, which is the Medicare Administrative Contractor, and there is an LCD that they had published on lower extremity major joint replacement, so it covers both hips and knees. So in that LCD, they're going to have listed indications, what patient presentations are considered appropriate for total knee replacement. Limitations when it's not considered reasonable and necessary to do a total knee. They're going to have listed in there your documentation requirements. And then they'll also have a billing and coding article that you need to reference as well. I'm not going to talk about that during today's webinar, but that will tell you which ICD-10 diagnoses codes are covered and which CPT or HCPCS codes are covered when you do these procedures. So you also have to not only meet the indications and documentation requirements, but you also want to make sure that you billed and coded it appropriately as well for coverage. If you need to find LCDs or NCDs, I've got the Medicare Coverage Database URL there for you that you can access.
One of the things with
go ahead.
This particular LCD that we've been challenged with by some of the contractors are they felt it was a requirement that the radiologist interpret the radiology study. That's not at all true. The ordering physician can interpret the study and document it in his or her progress note during the visit, and that counts towards this particular LCD. So we have had some confusion created by contractors who have felt that absence of a specific radiology report voided the appeal, and that's not at all true. The treating physician is more than qualified to interpret the X-ray and comment on it.
Yeah, very good point. You're right. We were just kind of discussing that recently. So you really have to pay attention to what does the LCD say. If it doesn't say you have to have a radiologist read your report, then you don't have to have a radiologist read your report. Okay, let me see if I can pull up my...
While you're waiting to pull that up, to the folks that are listening, quite often, if you're working from the operative report or the hospitalization, you may need to reach out to the referring physician or the surgeon and get their office notes prior to the hospitalization, because quite often the medical necessity for that particular procedure may be contained in an outpatient visit that's not incorporated into the hospital record during which the procedure was performed. So if that's the case and you can't prove the medical necessity, reach out, get the last outpatient visit, and quite often it'll be documented there.
Okay, so this one, as I was looking for cases, because like I said, I like to do real cases for you all. This one was audited by the RAC, and then the provider received a review results letter. Actually, they received, all I had access to was a demand letter that denied reimbursement for the surgery. I don't know specifically why Cotiviti denied it. It could have been an instance of where the hospital didn't get the notice and didn't respond to it. And so then ended up having to appeal it. I really don't know. Unfortunately, I didn't have that for this particular case. But I do want to point out that, if there is something specific that they are complaining about, just like what Dr. Smith just mentioned about a radiology report. Definitely you want to focus on that in your appeal argument. This one, I'm just going to kind of show you how we wrote what the patient's clinical presentation was and how that married up to the LCD. Okay, so this is an 80-year-old lady, advanced osteoarthritis of her right knee. She had a CT performed, which confirmed that. And then I have highlighted or bolded the bits of information that Novitas, the payer, is looking for in order to approve payment for her surgery. So complete loss of lateral joint space. She had osteophytes. She had pain with activity and weight bearing. Her pain interfered with activities of daily living. She had pain with passive range of motion. Her range of motion was limited by her pain. And all of that is going to be detailed more specifically in her medical record, like, you know, what activities of daily living was she having problems with and that type of thing. This is just an oversight of saying, you know, these things were occurring with this patient. She had conservative treatment, which included Aleve, Tylenol, physical therapy, and gel injections. And then we put in there page numbers of where in the medical record they could find that particular information. So that's something that we like to do is make sure all of our medical records have page large numbers in the top right-hand corner of the pages so that the reviewer can find that information quickly and easily. So she had a right total knee replacement done in an outpatient setting. And the hospital maintained that she did meet medical necessity criteria that supported her total knee replacement, and the hospital should be reimbursed for that. So now we're going to go to the LCD. So we have the title and name of our LCD. And this is another one of those examples where you can just pull that LCD up, just copy and paste what the indications are, put them you know, in your letter, create a template. And then all you have to do is go through and show which ones were met. So in this particular LCD, they say they need 3 or more of the following criteria met. So advanced joint disease by radiographic evidence. Okay. Doesn't say you have to have an x-ray that was read by a radiologist. Osteophytes, joint space narrowing. She had anti-inflammatory meds, analgesics, supervised physical therapy, and number 3, pain with functional disability due to arthritis, had an impact on her activities of daily living, and she had therapeutic injections into her knee. So she met 3 of the first 3. So very easy to connect the dots in this particular case. And just a nice little conclusion that says we ask you to reconsider the claim and make payment. Okay.
And if the patient's got a contraindication to NSAIDs, for example, they have an allergy or a history of bleeding ulcers, so they're on anticoagulation, acknowledge it in the letter, just confront it directly, say the patient was unable to, you know, tolerate NSAIDs due to an allergy or this, that, or the other. It may not be explicitly documented, so if it's not, you can reasonably infer it by pointing to the allergy list, etc.
Okay, so that's it. I'm going to have some closing comments here, and then we'll go to questions. Now, I talked about there's a survey that you need to complete if you want the CEUs. There's 3 questions related to the presentation. The third question is not related to the presentation. I don't know what I was thinking when I came up with the questions that I submitted for the CEUs 6 weeks ago. I have question number 3. I'm just giving you the answer. It's answer D, identify an appropriate resource for regulatory arguments, and it's D, the Code of Federal Regulations for Traditional Medicare. So I must have been in a sugar coma from all the Christmas treats, I guess. But why I put that question on there, I don't know. It doesn't have to do with this presentation. So just thought I'd go ahead and give you the answer. Okay, so in summary, the core of the medical necessity argument is services provided meet the standard of care accepted in the local medical community. The clinical picture and plan of care, plan for intervention must support standards of care. So you're just, as an appeal writer, you're connecting the dots, closing the loop, saying, yes, it does meet standard of care, pay us for it. And then standards of care, I just reiterated what Medicare says is their standard of care, because I think it's a pretty good definition of that. Okay, so hopefully you guys have put in some questions in the questions area. Give me just a minute to kind of get those opened up to where I can see them. And we'll see if Kendall and I can answer some of those for you guys. I don't know about you, but the print on my screen just gets smaller and smaller every year. Okay. Oh, this is interesting. So Linda says, what is the best way to appeal when a payer denies because medical necessity per MTG is not met? Their hospital is switching to a software program that uses, I'm not sure, Linda, what AT stands for, that uses AT that predicts status based on initial acuity. We will not have access any longer to interqual or MCG. So here's, I think I've talked about this before. Here's my thought on this. If you have a payer that uses MCG or interqual and you have had success in the past by showing them that they've misapplied interqual or misapplied MCG or applied the wrong standard, and you're able to argue that back to them and point it out to them, and they overturn your appeal, why not keep doing that? So I know there's some in the field that say, well, it really should all be based on standards of care. Shouldn't you, if you go back to the payer and say, well, you misapplied MCG, or you should have used this MCG criteria instead of that one, or whatever, they feel like you are backing away from the argument of standard of care. And actually, you know, to the core, yes, I agree with that. But on the other hand, we're here to get these overturned, and we've got to be efficient in getting it done. So if I can just do a simple argument back to the payer and say, you know, why you could have used this criteria instead of that one, and it would have met your criteria, and they're like, fine, we'll pay it. Why not do it? So anyway, that's my little spiel on that. If you don't have access to MCG or interqual, then you use your standards of care, because that really is what it comes down to. And say,
Hey, Denise, you just went silent. Denise? So I'll pick up while Denise logs back in. I think the challenges with MCG, as Denise was saying, where if you can simply overturn if you do have access to MCG, by pointing out an error or a misapplication of MCG, it's probably the prudent and quick thing to do, and choose your battles wisely. Often I've seen that the payers get limited information at the time of admission and apply an incorrect MCG. There may be a subsequent change in the patient's medical condition after admission, where a new or different MCG becomes applicable and appropriate. And at that point, it's appropriate to bring that to the payer's attention through the new medical evidence. Arguing the standards of care, I wholeheartedly would support what Denise has said. MCG, in fact, goes as far to point out that it's, in fact, structured for an idealized patient with an idealized hospitalization and idealized follow-up services, receiving idealized primary care. I mean, this is a theoretical patient they base these guidelines on. And in fact, when you go back and look at the majority of the articles from which the guidelines are based, none of them explicitly conclude that inpatient or outpatient was necessary based on those articles. Dr. Eddie Hugh and I from University of North Carolina and Denise have talked a lot about this, but you really are no double-blind randomized trials looking at inpatient or observation treatment for most medical conditions that are being denied, sepsis, respiratory failure, strokes, etc. And so MCG and Interqual infer a lot that arguing back using evidence-based guidelines from the original source, local standards of care and applicable standards of care is an appropriate way to engage. The goal ultimately in doing so is to try, if your contract allows, or if the type of insurance allows, Medicare, state Medicaid, is to get your letter to a third party, a state figure hearing, an independent review agency for consideration. By bringing forth those local standards of care arguments, evidence-based guidelines that Denise went through earlier, you've got a much better chance of winning over an independent reviewer or a state or federal administrative law judge to your argument in doing so. So I think the ultimate goal of these is realize that you're writing both to the insurance company, their medical director or nurse that issued the denial, but also that this letter may end up going and should, under all circumstances, go further than that if you don't get the results that you want, and ideally end up in the hands of a third party. So put your most persuasive argument forward. Point out that the nuance that Denise went through early on with your patients, their social economic conditions, medications, age, all of their comorbidities, how they interplayed, and realize that you'll probably, if you're able to get this escalated externally, you'll in all likelihood be able to win over a sympathetic third party with a really well-rounded 360-degree approach that she's put forward here.
Thanks, Kendall. Sorry, my call dropped and I had to dial back in. So thank you for taking the reins there. Okay, we're actually right up on the hour, but I'm going to just answer one more question. There's several more in here, like as our past webinars, we'll do our best to get a Q&A out there, and then also to answer your questions individually. So Felicia asked, for inpatient claims, I include a hospital course, a section that lists the peaks and valleys during the stay, including test results and procedures. Do you think that's overkill? I do think it's overkill because really it comes down to your argument should be based on what the patient looked like at the time the decision was made to admit them to inpatient. CMS, at least for CMS, they're not allowed to go back and to look at what happened later to say, oh, look, the patient none of those risks, manifested. The patient did fine. They got better right away, blah, 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 but we are allowed to state things like, the patient, this risk did manifest. And that was a consideration when the decision was made to admit the patient. We were concerned that the respiratory failure was going to become more severe to the point the patient was going to need to be intubated and put on a ventilator. Maybe it happened, maybe it didn't. But if it does happen, that just helps support that that was a concern the physician had. That's kind of my thoughts on that. Okay. We're at the top of the hour, so we're going to go ahead and close her down for today. Hope you sign up for our March webinar. Hope we'll see you on Wednesday or on Tuesday next week, January 31st, to talk about the proposed rule from CMS on Medicare Advantage. Hope you're going to join us for that one as well. And as always, if you have questions, you can reach me at denise@AHDAM.org. Thanks, everybody. Happy New Year. Hope you're having a good one so far, and we will see you either next Tuesday or in March.
Tuesday, please plan on attending Tuesday. The more people and comments we can get in to CMS from unique sources, the better chance that we're going to have of having things like interqual and MCG taken out of Medicare Advantage insurers' hands, and the easier life will become. So it's in everybody's interest to show up and learn how to comment, and we'll really look forward to seeing you again on Tuesday. So thank you.
Yeah, thank you, Kendall. Thanks for attending.